Good, and I'd like to invite audience participation, questions. Okay, I see a couple here. Please.
Hi,
Yeah.
I'm Dennis Johnson with the Children's Health Fund.
Dennis.
Maybe that was
I have a mic.
Yeah.
Can I ask you to use the mic?
Sure.
I'm sorry that I butchered the name of that tool.
That's right. You'll hear more about it from Roy tomorrow. Hi, I'm Dennis Johnson with the Children's Health Fund, and that was a terrific presentation on the environmental scan. Very interesting, an overwhelming amount of information to consume. But I wanted to ask a question about the interviewees, and in particular about something that I've become increasingly aware of in terms of where the health system is going, even beyond ACA. I was at a conference a couple of weeks back that the Financial Times put on navigating the move to value, the transition to value, and it occurred to me in listening to some of the speakers, while we're looking at ACA and what the implications of ACA implementation has meant for the issues we care about in terms of transportation, its impact on health, and how to define value and celebrate and leverage that value. But I was made aware of the fact that the health system transformation that's now in motion is going even larger with MACRA, which is the Medicare Access and Chip Reauthorization Act that was passed about a year and a half ago, that creates a whole new timetable for moving the health system to more of a value-based proposition. And I'm wondering, did any of the interviewees reference how they saw themselves interacting with the momentum that's gathering, right? I mean, the macros around Medicare, but as you know, Medicare being such a large payer is often the portal that other systems like Medicaid tend to mimic. So I was just wondering if there was any concern or conversation about that issue.
Yes, both concern and conversation. So I think that most of the interviewees were very excited that this conversation is happening, have seen it happen before, but recognize that we have some other forces that may create more momentum this time. And so I think part of the so many folks bringing up that value question as opposed to just the healthcare savings question was because they recognize that it's important, but also that they're gonna need to do it for funding and for regulations coming down the line and how that's going to work in the future. And so I think that folks were both really excited about that because they felt very concerned that a narrow focus on healthcare savings wasn't sufficient. But there's a lot of trepidation and anxiety about how we're going to do it, how we are going to measure those larger value questions. And so really looking to the folks in this room and watching and to start to move that forward and to figure out how we're going to do that and to learn from each other as they're moving that forward. But it was absolutely a theme that came through, and I think really part of why I quickly got redirected in most of my interviews from talking about healthcare savings to talking about that bigger universe.
A good question, Dennis, and we have another question from the audience, but then I want to ask as a concluding question, sort of following up on that, because my career, the bio in the packet says 33 years, it must be 4 years old, because 37 years in the business, and we've been talking about this issue of coordination that whole time, right? And the fact is, it's become, paratransit trips have only grown in the public transit sector, and they've only become more expensive, right? So we have to make progress. And I'd like to ask the panel, as concluding, we're not going to solve it today, but what is data and metrics that can help us along our quest? So we're going to conclude with that question, but we have another question to take here. Thank you.
I'll make it really quick, but I know Heidi said it was too much on funding, but I would ask that anyway. Real quickly, on the healthcare side with community health centers, one of the things that we found around funding for outreach, which enabling services where transportation falls, two things that we found can have an impact quicker with that, and I'm wondering if any of that came up, is that the challenge with enabling services on the healthcare side with that is that funding for it is episodic and or disease specific. So it's really hard to really let alone evaluate the program, but demonstrate impact. And so one of the things that we've mentioned with HRSA is the importance of getting beyond, well, the disease specifics are always going to, that happens, but beyond that, just the episodic funding, most of them, it's 1 year, 1.5, and just to ramp up and then wrap up, it's very, so there's things in it that make it difficult to demonstrate impact and value. And that's one of the things that I know HRSA is really trying to change with some of that funding. And I'm wondering if that sort of came up in you, because those are things that can be recommended, I think, that can start changing things quickly. Did that come up, or, yeah?
Yeah, and so that theme of going slow, which will change to going deliberately, and really kind of thinking about that sustainability was part of that, right? So folks would get this funding, they would do a program, the funding would disappear, the program would disappear, and folks would become reliant on that program or that tool, were left potentially in a worse situation, and so that certainly came up, and a couple. And that came up with the founders too, the funders too, the foundations. Was them trying to figure out how they could do it. I mean, some of the successful models of folks who I talked to, almost a bake sale, right? I mean, folks were just doing as small of a program as they could manage by raising money in their community, because they could count on the community to pitch in an X amount of money every year, and those were very, very small programs. In Oregon, we have a special transportation fund. I think a couple states have something like that, where funding that's not part of veterans or paratransit or Medicaid NEMT is the state provides this money out, and it's really flexible, and it's allowed some of our transit providers to do some of that gap filling, and it's a regular pot of money. We increased it in our last legislative session, and so some of those tools exist, but more often than not, the gaps are being filled in these episodic ways, and so that's part of that time scale conversation too, because they're being filled in episodic ways and expected to show returns pretty quickly to get more money, and that's not necessarily happening. One case that I'll bring up, because it was interesting, was sometimes you can measure it on staff time at the hospital. And so, if the social workers or the nurses are spending a lot of time on transportation, that's one way to monetize really quickly the impact of a program. And that was about the only thing that I heard that was, a really quick turnaround. We could see this impact really fast, but didn't necessarily rise to the level of the investment, but still might have seemed worth it to the hospital. But that episodic funding was a big thing, big problem.
We're going to run out of time here, but let's try to, if you ask them very fast, and let's try to respond very fast. We'll take both of them, A and B.
Yes. Kate Lawson, University of Albany. Quick question about land use, especially being in Oregon. It seems to me that they are going to be a big stakeholder if we move deliberately. Did you hear anyone encouraging the industry to start moving into empty shopping center spaces with different facilities, because they're on the transit system most likely? In other words, that coordination with our partners on the land use side.
No one said that, and I didn't lead them into saying it as much as I might have liked to. And I think that's going to be a pretty big deal for the transit providers. And I'm not sure what levers exist, but I can imagine some levers, as I imagine you can as well. And so it's certainly a conversation that I think should be happening.
All right.
Great. Thank you for the opportunity. Martin Ornelas with Real Incorporated, the Rural Economic Assistance League. We operate a rural transit district in 9 rural counties in South Texas. South Texas, I don't mean San Antonio. I actually mean further south of San Antonio. We're actually central between San Antonio, the border, Corpus Christi on the east, and Laredo on the west. I wanted to bring two quick observations. One is the importance of developing rural models based on rural realities, not the application of urban models into rural, or making it the trickle effect that what applies in rural areas will apply, in urban areas will apply, because that certainly is not the case. I want to also comment that in urban areas, we know that paratransit is the most costly. The closest type of model in rural areas is a paratransit type of system, a demand response. And so imagine an area that has scarcity in resources and yet has to implement a service that's the costliest in greater distance. If you can imagine the metropolitan area without the population and having a population of 240,000, and yet you still have all these little towns, Bethesda, Rockville, Fairfax, et cetera, and have to move people to specialty care, it's costlier. And so the cost to the individual, it's higher, less access, et cetera. And let me just leave you with two. The important thing that I think also needs to be kept in mind is that in rural areas, we have what we call transportation shortage areas. We understand about health service areas, medical service areas that are a shortage. We have transportation shortage areas. And the other thing that I think in part we're trying to do here is create a new model, and I would call it an integrated model between transit and health. We know integrated model in a healthcare setting, primary care and behavioral health. I think we can apply the same concept into transportation and into health. Thank you.
Good points. I think we'll leave it at that. And Isela, I think we turn it back to you at this point, having 10:10. We can keep going if we have time, but the schedule says 10:10. So thank you, Judy, and thank you, Heather, very much.
Thank you. Let's give them a round of applause, please.
And thank you, Heidi.